Hello class, I'm Rachel Kerrigan. I'm a TA for the MHPS program, and I'm going to talk to you today about chapter 12 in your text. Oh, excuse me. And that's about substance use and mental health disorders and neurological disorders and effective interventions and to consider when thinking about treatment. So I'm going to share the screen here. All right. Okay, the text starts out with this concept of therapeutic nihilism, and this is something that perpetuates the treatment gap worldwide, this idea that mental health and neurological and substance abuse disorders are not treatable. So there's this kind of radical skepticism that there's anything the health sector can do in terms of treatment for these kinds of disorders. We need to consider when people are looking at managing mental health disorders generally, that in many places in the world, people are relying on self-care or the informal sector for support. So this includes church and religion, family and friends, even traditional healers, often traditional healers. And it's important to recognize this, although the book focuses, and we're going to focus today on interventions for MNS disorders that are more where the evidence is most developed. However, it is important to keep those in mind, and at times it's even appropriate to integrate some of these beliefs and considerations into treatment. But we'll talk about that later. All right, priority mental, neurological, and substance use disorders defined by the WHO include things like depression, alcohol and drug use, suicide and self-harm, psychosis, bipolar disorder, epilepsy, dementia, and then child developmental and behavioral disorders when talking about this category that they have researched. And epilepsy and neurological disorders are included because they're often managed by the mental health sector in middle and low income countries. So whereas they may be managed by specialists or more the health facilities in the US or other places, they're often kind of thought of under the umbrella of mental disorders and substance abuse disorders. All right, we're going to look at 5 principles to consider of intervention. And again, I'm just going over the text here, and this video can help you in preparation for your quiz for chapter 12 as well. So we're going to talk about effectiveness first. And to determine effectiveness, this requires research. And as I know Dr. Herbie has told you, most research is done in high-income countries. The book estimates 1% based on some research some other literature is done in lower income countries. So certainly there is a need for more literature and studies and research done in low and middle income countries. Of course, we know randomized control trials offer the best evidence because interventions are allocated randomly to participants. It's highly controlled, high internal validity. However, those kind of studies are great in the lab, but they're not always feasible and ethical due to all kinds of constraints in the real context. So the book distinguishes between efficacy and effectiveness. So efficacy asks, does the intervention produce results under ideal conditions? So again, this is high internal validity, it's highly controlled. And then effectiveness is asking whether the interventions interventions in usual circumstances, whether or not they are the interventions does what it's supposed to do, more unusual circumstances. So the nice thing for this is they are more feasible, these kind of studies, because there's a broader eligibility criteria. It's more tied often, the questions and kind of the process for the The questions that the research is asking is more tied to priorities of the patients and healthcare providers. So it's more generalizable. It has a lower internal validity, but it has a higher external validity. It's more generalizable. So that's important to consider when you're looking at research, or if you ever are considering to do research. Another principle is feasibility. So thinking about, is this intervention possible? There's a shortage of mental health professionals worldwide. So this is a huge limitation. The WHO reports in a recent article, or a recent, I just looked up for another paper I was writing, I looked up that the global shortage of mental health care workers has rates as low as 2 per 100,000 in many countries, compared with more than 70 per 100,000 in high-income countries. So this is from 2018. It's a couple years old, but still there's certainly a shortage of mental health care professionals. And so often we are sharing that burden with healthcare workers or in other sectors to meet the needs of people. Also, high staff turnover and laboratory service availability. I think the text even mentioned lithium levels as something that can be a limitation for implementation to prescribe lithium for example, bipolar patients. I know in Rwanda, in the context I live, there's only one place in the country that offers laboratory results for lithium levels, and that's required for someone taking that medication. They need to get their blood checked, their lithium levels checked regularly. So it limits the feasibility of utilizing that intervention for many people. And that brings us to the next point, equity. So perhaps people in Kigali could be prescribed lithium because they can get their blood levels checked, but it might be much more difficult in the country side where lithium levels are not available to prescribe lithium. So that is an equity issue. Vulnerable populations are often already at risk to being excluded. So this is talking about how certain social determinants often exclude people from services. So you want to focus on that when thinking about intervention, and thinking about, is there an intervention that I can equitably distribute to the population that I am trying to reach. Also prioritizing people with MNS disorders for inclusion in development activities. I even think of this with NGOs going into communities. My husband works for World Vision, and figuring out how to include those with MNS disorders in some kind of development activities and to make sure that there's equity in intervention. Excuse me. Acceptability. Is the intervention relevant? So here we get into this sociocultural aspect. Often this is presumed with mental health disorders that the cause lies in the supernatural realm. And we see that a lot here. People often, especially in the rural areas, go to witch doctors and traditional medicine as a first resort, because maybe that's what their family has done, that's what they have access to, that's what they can afford. However, there needs to be caution because, of course, any kind of interventions, especially in traditional medicine, have not been validated, and there have been. The text talks about some concern for whether or not some of those procedures are ethical, and there's not a good way to evaluate that without research. So we can't necessarily recommend those. However, there is some research. I just came across an article that I put in the references actually that talks about the importance of considering especially religious beliefs and thinking about interventions that can accommodate or include or integrate spiritual beliefs for people into some of the process. So certainly things like prayer and meditation align with mental health interventions. So considering people's cultural, sociocultural factors is very important, and exploring those and figuring out what they're doing or what would be helpful and ethical is important to consider. The adaptation of effective Western therapeutic interventions is challenging because of cost and stigma. I put in this example because it said implementation of biomedical interventions in Ethiopia is now in high demand because it's effective. So sometimes when you put a new intervention in that's highly effective, the word gets out quickly, especially in these communal societies. I lived in Ethiopia, and the fistula hospital, for example, is very, very busy, and that hasn't been around forever. So there's a shift from traditional ways of intervening with that problem to these utilizing medical services because the word spreads. And then contextually acceptable, and this is another piece, is whether or not is the context important. So they talk in this study, in the book, about thinking, for example, in Pakistan, to treat maternal depression, they found out if they focused on how treating depression for the mother impacts the child, that was actually more effective in getting people to utilize treatment for depression than focusing on the need for the mother. So sometimes understanding the context and what will help a community see the importance of an intervention needs some research itself, some qualitative research on what kinds of things are important in this community when trying to advocate for maternal depression treatment. Is it focusing on the importance for the mother, or is it focused on the child, or is it focused on the community, the impacts of the community who has treated someone for depression? So considering, the communal cultural aspect can be very important when considering interventions. In many countries, not every country is community focused, but many are. And then, of course, affordability. You need to look at both direct and indirect costs. So direct costs are things like the cost to go to the doctor, the cost to purchase the medication. Indirect costs are losing work and the impact of the community when someone isn't able to go to work. And so those kind of things are indirect costs. All right, now we're going to look at intervention. First-line interventions can be delivered by non-specialists with some medical training. So you need some training to deliver these, but you don't need to be a specialist. So again, we talked about how there are not enough people, and so it's important to figure out who can intervene. Psychological first aid is one example. This reduces stigma by improving basic knowledge to the community members and equips people with simple skills like assessing for suicide, listening non-judgmentally, giving reassurance and encouragement to people. So these kind of skills, although traditionally done by mental health providers, can be taught to nurses and to healthcare workers and to social services people. So again, this is a task sharing thing that helps increase access. Psychoeducation improves understanding of mental health disorders for patients and caregivers. So sometimes a training or pamphlets about, okay, what is maternal depression? What is bipolar disorder? What is psychosis? To help increase both those working in the health facilities, but also for patients who may be suffering or have family suffering. interventions continued. So this is more interventions. So this is something that may require a little bit more psychological training, and they're, although usually delivered by specialists, can be delivered by non-specialists with more supervision. So this is talking about more specific strategies that we know are effective from the literature, things like CBT, behavioral activation, interpersonal psychotherapy, problem-solving techniques, relaxation therapy. These things are very effective and easily kind of taught to the lay helper if they're interested in and willing to engage in some training and then supervision to assist in providing knowledge of these techniques to people in the field. Social interventions, this talks about combating social adversity, things like poor housing and intimate partner violence, poverty. These are all things that put you at risk for more mental health disorders. So the text talks about two kinds of recovery models. First is actually two different interventions. First, a recovery model. This is not always full clinical remission, but learning to live well with enduring symptoms. So for example, someone with a major mental health disorder may still have some enduring symptoms. However, they can learn to live well. We know, for example, with bipolar disorder, with good interventions and some CBT skills and some crisis management preparation, there can be things that can be taught and implemented to help manage that illness, along with access to psychotropic drugs often, that will help stabilize that person and help them to live well while they may still have symptoms here and there. And then another intervention is community-based rehabilitation. And this is improving the quality of life for people with disabilities by helping them meet basic needs and participate fully in society. So again, we kind of mentioned this before, bringing people into the community, taking away stigma by providing education or just allowing for more participation in society. Okay, we're going to talk quickly about the World Health Organization's mental health gap implementation guide. So they did a big study, a rigorous, systematic, transparent evaluation of existing interventions, and produced a package of care based on evidence-based guidelines. And you can see this in your text. It has a lot of the guidelines, and it gives you a link to look at the entire report if you'd like. So I'd suggest, especially if this is an interest of yours, to look more carefully at this. But basically, the framework that they used is based on, or comes from the chronic disease model of care. And they have two different models. The first is a collaborative care model. This requires active collaboration of patient caregivers and generalists and specialists from healthcare workers and organizations from non-healthcare sector organizations. So this is a collaborative model where everyone is working together. The stepped care model tailors disorder-specific treatments according to the severity of the disorder and the initial response to treatment. So not everyone is given, for example, medication for depression. If they're not severe, they don't get medication, but someone who's more severe would get medication, for example. So considering stepped care interventions is this recommendation. So basically kind of two different models. One is, let's include everyone together, this collaborative care, and also let's consider a stepped model care and only provide people what they need, not go over those requirements. Again, these recommendations are aimed to increase public awareness, mental health literacy, reduce stigma, overcome access issues, and improve physical health outcomes of people with M and S disorders. So again, it's a really helpful model to look at. And then these are areas requiring further efforts: cultural appropriateness, Again, we talked a bit about this, but is the intervention contextually appropriate for the society or the place that you're working? Second, implementation evidence that seeks to identify the most effective, equitable, feasible, accessible, and affordable ways in which interventions should be delivered in different sociocultural settings. So, looking at implementation evidence, considering all these things we talked about, what, um, which intervention should be delivered. There needs to be more research into newer, more effective pharmacological and psychological and social interventions. So this is always a need for studies. I just read another article that was talking about the importance of deliberate care, that we as clinicians are called to be deliberate and in our care by continuing to learn new interventions, and that effectiveness is tied to that quality. So we need to know what actually is effective in these contexts. Traditional and religious healer intervention. Again, this is an area that needs more study. So that's what the text concludes, that we can conclude that it's neither good nor bad. I put in this article because it has an example of ways that this one study implemented some religious interventions that were in line with the culture that they were working in. So interesting article to look at, but again, be cautious. Some of the traditional healing certainly has not been proven and can result in abuse or things we would not want for people. So with caution, we need to consider these things. And here are the references. I'll add the WHO article that I referenced here before I send the slides to Dr. Hervey as well, if you're interested. And thank you for listening.